So, I want you to picture an earthquake, right, hitting a massive, densely populated city.
Right. A catastrophic event.
Exactly. And the initial mechanical tremor, the actual shaking of the ground, it lasts, what, maybe 20 seconds?
Usually, yeah, very brief.
Right. And it collapses a few vulnerable buildings. But in the grand scheme of things, that immediate physical destruction is remarkably contained.
Which is counterintuitive, but true.
Yeah, because the real devastation, I mean, it's the subterranean water mains snapping and flooding the transit tunnels. It's the electrical fires sparking in compromised power grids and just, spreading for days.
The secondary effects.
Exactly. It's the structural rot and the socioeconomic decay that quietly hollows out the neighborhood over the next decade.
That is honestly the perfect way to look at it.
Because a traumatic brain injury, a TBI, is not just an event. It is not the 20 seconds of shaking.
No, it's absolutely not.
It is the violent initiation of a cascading progressive crisis. And today, we are pulling apart the Kaplan and Sadok chapter on the neuropsychiatric consequences of TBI, breaking down the exact mechanics of that crisis.
Which is really the only framework that makes sense for this pathology,
How so?
Well, if you are a registrar assessing a patient in A&E or managing a chaotic ward, and you view a head injury purely as a static orthopedic problem.
Like a broken arm.
Right, like a broken bone that just happens to be a skull, you are going to miss the entire clinical picture.
Completely.
Because psychiatry is fundamentally the study of how the physical brain, the subjective mind, and external experience interact.
Right. That's the core of what we do.
And TBI forces us to confront the reality of what happens when the physical hardware is acutely deformed. I mean, how does that mechanical shearing translate directly into altered cognition, fractured emotional regulation, and entirely shifted identities?
And that's the mission for this deep dive. We are moving systematically from the physics of the trauma, through those cellular fires, all the way to the long-term neurodegenerative shadows.
Building a complete mental model.
Exactly. So that you, the listener, understand exactly why your patient is behaving the way they are.
Not just what the symptoms are, but the underlying why.
Spot on. So let's start with the sheer epidemiological footprint. We all know TBIs are common, but the numbers in the text are just staggering.
Oh, they are.
I mean, we're looking at nearly 3 million A&E visits, hospitalizations, and deaths annually in the U.S. alone. The global burden is just astronomical.
It is a colossal public health burden. I mean, we're talking tens of billions of dollars annually. But what's really vital for a clinician to understand here is that the risk, it's not evenly distributed across the population.
Not random.
Not at all. It follows a very distinct trimodal demographic curve.
Okay, break that down for us.
So you have high rates in infants and toddlers. Then there's a massive, sharp spike in adolescents and young adults. And finally, another significant peak in the elderly.
To 3 distinct peaks.
Exactly. And you have to add a stark gender disparity to that. Males are roughly 40% more likely to suffer a TBI than females.
Which, I mean, the mechanisms behind those peaks make intuitive sense, right?
Yeah, they do.
Infants and the elderly are falling. Falls are actually the single most common etiology across the board, aren't they?
They are, yeah. Across all age groups combined, falls take the top spot.
But that middle peak, the young men, that's where the etiology shifts sharply to motor vehicle collisions and assaults.
Exactly. High velocity impacts and violence.
And this brings me to a statistic in the text that honestly, it completely changed how I view these cases.
The premorbid vulnerabilities.
Yes, because there is this pervasive narrative that a TBI is just a random stroke of bad luck. You were just in the wrong intersection at the wrong time.
A bolt from the blue.
Right. But the text notes that nearly 1/3 of brain injury patients had a pre-existing identifiable alcohol use disorder before the trauma even occurred.
It's a huge proportion.
And more than 50% were acutely intoxicated at the exact moment of impact.
Yeah, that statistic should fundamentally alter your clinical approach. I mean, it destroys the myth of the random accident.
It really does.
The behaviors, the impulsivity, the untreated ADHD, and the substance use that predispose a patient to an initial trauma, they don't just vanish simply because the patient is now lying in an ICU bed.
Right, the brain injury doesn't cure the alcoholism.
Exactly. In fact, the biological damage often strips away whatever compensatory mechanisms they had, which severely exacerbates those pre-existing vulnerabilities.
So it creates this terrifying feedback loop. The vulnerability causes the injury, and then the injury worsens the vulnerability.
Precisely, which explains why the recurrence rates are so astronomically high.
What are we talking, numbers-wise?
About 10% of these patients will sustain a second recurrent TBI within 12 months.
Within a single year.
Yes. And when researchers look at the variables, the primary driver for a second TBI isn't the severity of the initial physical damage.
Oh, really?
No, nor is it lingering motor deficits. The single greatest risk factor for recurrence is ongoing substance abuse.
Wow.
So if you are a psychiatrist treating a patient post-TBI and you ignore the addiction component, you are virtually guaranteeing they will end up back in A&E with a second, far more devastating injury.
The hardware was already running faulty software, and then someone took a hammer to the motherboard.
That's a brilliant way to phrase it, yeah.
Well, let's talk about that hammer. Let's get into the mechanisms and models, the actual physics of a closed head injury. The text draws a very hard line between primary and secondary injury.
It does. So the primary injury is the absolute immediate mechanical deformation of tissue.
The shaking of the earthquake.
Exactly. It is the tearing of blood vessels and the physical stretching of neurons at the exact millisecond of impact.
And the secondary.
The secondary injury comprises the delayed physiological cascades. So, the spreading edema, ischemia, rising intracranial pressure, and excitotoxicity.
Yeah.
And that unfolds over the ensuing hours, days, and even weeks.
Let's visualize the primary physics first. Because if you understand the physics, the clinical presentation maps out perfectly.
It really is just pure mechanics.
Right. So the brain is not a solid, dense muscle. It's a semi-firm, gelatinous mass, right? Yeah. Suspended in cerebrospinal fluid.
You'll get dense jelly, yeah.
And it is completely sealed inside a rigid, bony vault. But the floor of that vault is not smooth.
Far from it.
The anterior and middle fossa, so the areas right behind your eyes and temples, they are lined with these sharp, bony ridges.
Right, the sphenoid wing and the orbital roofs.
So when a patient hits a windshield, their skull stops instantaneously.
Boom. 0 miles an hour.
But inertia dictates that this gelatinous mass inside keeps moving forward at 60 miles an hour.
Exactly. The brain violently impacts the interior of the skull. But it's not just a flat impact, right? It's a dragging motion.
A dragging motion.
Yeah. The ventral surfaces of the frontal and temporal lobes are brutally scraped across those sharp, bony protuberances at the base of the skull.
Oh, God.
And furthermore, the brain is compartmentalized by these incredibly tough, rigid dural membranes.
Like the falx cerebri.
Right, the scythe-like falx cerebri dividing the hemispheres and the tentorium cerebri separating the cerebrum from the cerebellum.
They're like internal walls.
Unyielding, fibrous dividers. So during a rapid acceleration-deceleration event, the brain isn't just hitting bone, it is forcefully impacting and slicing itself against these internal dividers.
It's literally like throwing a block of soft tofu against a cheese grater.
That is exactly what it looks like on pathology. This macroscopic scraping leads to hemorrhagic contusions.
The bruising.
Yes. And because of the anatomy of the skull we just described, those bruises are highly concentrated on the crests of the cerebral gyri in the frontal and temporal lobes.
So if you are listening to this on a ward, that is your primary anatomical anchor.
The frontal and temporal lobes take the mechanical brunt.
Which means the ensuing psychiatric symptoms are going to be overwhelmingly frontal and temporal.
Executive failure, emotional dysregulation, loss of impulse control.
But contusions are just the macroscopic bruises. Let's talk about the silent killer. Diffuse axonal injury, or DAI.
Right. DAI is the quintessential neuropathology of trauma.
Because it's not about hitting the skull, is it?
No. While contusions are caused by the brain hitting the skull, DAI is caused by the brain twisting upon itself.
Twisting.
The rapid rotational and tensile shearing forces physically stretch the incredibly delicate axonal tracts.
I want to pause here because this is a perfect clinical reasoning check. If I'm looking at an MRI of a patient with profound DAI, why is the damage almost always localized to the corpus callosum or the gray-white matter junctions?
That's a great question.
Because it's not like the skull is hitting the dead center of the brain. What is the actual mechanism making those specific areas so incredibly vulnerable?
It all comes down to tissue density gradients.
Okay, how so?
Well, gray matter and white matter have different specific gravities. They have different elasticities.
They stretch differently.
Exactly. When a rotational force is applied to the brain, these two tissues move at slightly different speeds and stretch to different degrees.
But they pull apart.
Right. The interface where they meet, the gray-white junction, becomes this massive fault line. The axonal tracts crossing that junction are subjected to immense shearing forces and are physically torn.
And what about the corpus callosum? That's deep in the middle.
Its vulnerability is a matter of geography. It sits immediately adjacent to the rigid falx cerebri.
That fibrous divider we talked about?
Yeah. As the hemispheres twist, the corpus callosum is effectively dragged across that sharp dural edge,
Just sawing through it.
which severs the massive communication networks between the left and right hemispheres.
So the twisting, not the direct impact, causes the tearing.
Exactly.
That completely changes how you view a whiplash injury where the head never actually strikes an object.
You don't need to hit your head to have a severe traumatic brain injury.
So we have the macroscopic bruises and the tearing of the networking cables, but the text gets incredibly granular about the microscopic cascades.
This is the secondary injury.
Right. What actually happens inside the neuron when it is violently stretched but not completely severed?
It initiates a cellular meltdown.
Walk us through that.
So when an axonal membrane is physically stretched, its mechanical deformation causes the ion channels to spring open inappropriately.
They just pop open from the physical stretching.
Yeah, and this completely disrupts ion homeostasis. You get a massive, unregulated efflux of potassium out of the cell and an influx of sodium into the cell.
Which is the opposite of what should be happening.
Exactly. To restore the balance, the neuron's sodium-potassium pumps go into absolute overdrive, rapidly depleting the cell's ATP stores.
So the cell is just burning through all its energy just trying to stay stable.
Yes. And while it's failing at that, the terminal axons are dumping massive amounts of the excitatory neurotransmitter glutamate into the extracellular space.
The glutamate storm.
The glutamate storm. This excess glutamate binds to NMDA and AMPA receptors on neighboring cells, forcing their calcium channels open.
So now calcium is flooding in.
Intracellular calcium skyrockets, and this calcium flood is highly toxic
Why is it toxic?
because it activates destructive enzymes like calpains and caspases, which begin to literally dismantle the cell's cytoskeleton from the inside out.
It's digesting itself.
Essentially, yes. It also uncouples mitochondrial oxidative phosphorylation, which leads to the generation of highly reactive free radicals.
And I imagine the immune system notices all this chaos.
Oh, absolutely.
Huh.
Finally, this widespread cellular distress activates microglia, which are the brain's resident immune cells.
Right.
And that initiates a wave of neuroinflammation that can persist for months or even years.
It's the equivalent of a nuclear reactor's cooling pumps failing. The initial physical jolt was the earthquake, but the glutamate storm and the calcium influx are the ensuing radioactive fire that just keeps burning.
That is exactly what has happened on a microscopic level.
Before we move into how this massive physical and chemical damage looks clinically, we need to address a very specific etiology: blast injuries.
Ah, yes.
Because the text highlights TBI as the signature wound of recent military conflicts. Now, I understand the shrapnel and the impact of being thrown, but what is a primary blast wave actually doing to the brain?
The primary blast injury is completely unique to explosive physics.
Okay.
When an improvised explosive device detonates, it creates a supersonic overpressure wave,
A wall of air.
a wall of highly compressed air expanding outward faster than the speed of sound. And when this wave passes through the human body, it violently compresses and then rapidly expands tissue.
Which must wreak havoc on internal organs.
It is particularly devastating wherever tissue densities change abruptly, which is why the tympanic membrane ruptures and the lungs suffer hemorrhage, air fluid interfaces.
If the brain is in fluid.
Right. In the brain, this pressure wave induces cavitation.
Cavitation.
Microscopic bubbles form in this cerebrospinal fluid and the interstitial fluid.
From the pressure change.
Yes. And when the low pressure phase of the wave follows just a millisecond later, these bubbles violently collapse.
Oh, wow.
They release immense mechanical energy
Right.
right at the cellular level, instantly initiating the exact same glutamate and calcium cascades we just discussed.
But across the entire brain simultaneously.
Exactly. Not just localized to a contusion, everywhere.
That is deeply unsettling. The wave literally boils the fluid at a microscopic level for a fraction of a second.
It does.
So you have the primary overpressure wave, the secondary shrapnel, the tertiary impact of the body being thrown against a wall, and the quaternary toxic gas or burns.
And a single patient can experience all four simultaneously.
No wonder the clinical presentations are so profoundly complex.
They are some of the most complex patients in medicine.
Which brings us to the clinical manifestations. When this patient rolls into your care, how do we categorize the damage?
Well, acutely, we rely on established triage heuristics to define the injury as mild, moderate, or severe.
The classic classification.
Right. And this classification is primarily based on the Glasgow Coma Scale, the GCS score. At the time of presentation, the duration of any loss of consciousness, the extent of post-traumatic amnesia, and the degree of alteration of consciousness.
But those are just acute markers, right?
Exactly. They're designed to guide immediate neurosurgical interventions.
Yeah.
Do we need to drill a hole? Do we need to intubate?
Right.
They do not perfectly predict long-term psychiatric outcomes.
Let's trace the chronological recovery pathway for a patient with a moderate to severe TBI. The text calls this acute traumatic encephalopathy.
It's a very distinct progression.
A patient suffers massive trauma and is plunged into a neurologic void. Now, we don't need to define the basic GCS mechanics of a coma. Our listeners know that. But the transitions out of that void are where the psychiatry consults get really complicated.
They do, because emergence is chaotic.
So how do we distinguish a minimally conscious state from the onset of the post-traumatic confusional state?
It's all a matter of tracking the return of functional networks. So in a vegetative state, the sleep-wake cycle has returned. Their eyes might be open, but there is zero awareness.
Right.
Then, in a minimally conscious state, you start to see reproducible, albeit inconsistent, goal-directed behaviors.
Like what?
Tracking a mirror with their eyes or reaching for a feeding tube.
But they aren't fully awake.
No. But the major transition occurs when the patient enters phase 2, the post-traumatic confusional state.
Which is basically delirium.
It is, for all intents and purposes, a profound acute delirium. The reticular activating system in the brainstem has recovered enough to sustain wakefulness, but the higher cortical networks are still completely chaotic.
The text has a vivid vignette for this. A 19-year-old motorcyclist. He suffers bilateral anterior temporal hemorrhagic contusions, again, right where the brain scrapes the skull base.
Classic injury pattern.
48 hours later in the ICU, he suddenly becomes violently agitated. He's ripping out his arterial lines, fighting the nurses, and swatting at visual hallucinations.
The terrifying scene for the family.
And the staff. But if you are the psychiatry registrar paged to the ICU at 3 a.m. for an agitated psychotic patient, you have to recognize that this is not a primary psychotic break.
Absolutely not. This is the structurally expected, albeit terrifying, confusional state of a brain emerging from severe trauma.
Why does it look like psychosis?
Well, the prefrontal regulatory networks, the brakes, are completely offline. And the temporal lobes, which process sensory input and emotion, are bruised and bleeding.
So the brain is just misfiring completely.
The patient is flooded with unmodulated, terrifying stimuli. The clinical challenge here is walking a tightrope.
Between safety and recovery.
Exactly. You must ensure environmental and pharmacological safety, preventing them from extubating themselves, without sedating them so heavily with neuroleptics that you artificially suppress their neuronal recovery.
Because blocking dopamine when the brain is trying to heal isn't ideal.
It can drastically slow recovery.
So as the swelling goes down and the delirium begins to clear, they transition into phase 3, post-traumatic amnesia or PTA.
This is a critical phase to understand.
Now, I always struggle with the terminology here. When a patient's family hears amnesia, they immediately picture a soap opera scenario where the patient has forgotten their own name and their entire childhood.
Right, the classic retrograde amnesia trope.
But that's retrograde amnesia. What we're really talking about with PTA is a broken save button, right?
That is the perfect analogy. During the PTA phase, the patient's basic arousal and simple attention have actually recovered.
So they look awake and engaged.
You can walk into the room, and they will hold a coherent, normal-sounding conversation with you.
But
the hippocampal formations, which are responsible for consolidating short-term experiences into long-term storage, are still metabolically dysfunctional.
the save button is broken.
Exactly. You can have a 5-minute chat, leave the room, return 10 minutes later, and they will have zero recollection of ever meeting you.
That must be so disorienting for families.
It is. And the duration of this specific inability to form new continuous memories is actually one of the most powerful prognostic indicators we have for long-term functional recovery.
The longer the PTA, the worse the prognosis.
Exactly.
So eventually, the hippocampus comes back online, the save button is repaired, and PTA clears.
Right.
But here's the cruel irony. Often, families will say the patient suddenly looks worse cognitively once the PTA clears. Why does that happen?
Because the clearing of PTA unmasks phase 4. Post-traumatic dysexecutive syndrome.
Unmasks it, so it was always there.
Yes. During the confusional and PTA phases, the cognitive deficits are so globally overwhelming that you cannot accurately assess their higher-order executive functioning.
You can't tell if their planning is broken if they can't even remember the plan.
Precisely. Once they can finally remember what day it is, the damage to the frontal subcortical circuitry becomes blatantly obvious.
It's the difference between an encoding failure and a retrieval failure.
Yes.
If PTA was the broken save button on the keyboard, the dysexecutive syndrome means the hard drive works, but the file management system is completely corrupted.
That's a great way to think of it.
They can't organize a search to retrieve the memory.
Right. They have immense difficulty with free recall, their working memory is fragmented, and they cannot formulate a sequence of actions. They lose the ability to plan.
Which is entirely consistent with those frontal lobe contusions.
And the shearing of the frontal white matter tracks, yeah. They may have a full vocabulary and perfect motor function, but they cannot manage a bank account or organize a trip to the grocery store.
It's a profound hidden disability.
It really is.
So that maps the devastating trajectory of severe trauma. Let's pivot to the other end of the spectrum. The text uses the term mild TBI or concussion.
A very loaded term.
Because calling brain damage mild has always felt like a dangerous clinical oxymoron to me. We are still talking about the rotational shearing of axons.
It is a profound misnomer, and it often leads to inadequate follow-up.
Why is that?
Because the critical point is that a patient does not need to lose consciousness to sustain a mild TBI.
You don't have to be knocked out.
No. An alteration of consciousness and AOC is sufficient.
What does that look like in practice?
If a patient is involved in a collision and is dazed, staring blankly, or unable to perform simple cognitive tasks like serial sevens, counting backwards by sevens, immediately following the impact, they have suffered an acute disruption of neural networks.
The damage is done.
The excitotoxic glutamate cascade we talked about has been initiated, even if they never blacked out.
And the controversy always surrounds post-concussive syndrome, doesn't it?
Oh, always.
Because most guidelines say objective cognitive deficits should clear within 3 months. But we both know clinics are full of patients suffering from headaches, photophobia, intense irritability, and brain fog a year later.
The persistence of those symptoms beyond the 3-month window is complex, and it heavily involves our field, psychiatry.
Because it's psychological.
Well, the data clearly shows that pre-existing psychiatric conditions, anxiety, depression, somatization disorders, are the strongest predictors for the persistence of post-concussive symptoms.
Wait, does that mean they are just making it up?
No, absolutely not. This does not mean the symptoms are all in their head or malingered. Right. It means the structural injury to the brain has intertwined with a pre-existing psychological vulnerability, creating a highly resistant chronic symptom complex.
The hardware and the software are inextricably linked.
Exactly. You can't separate them.
Which is the perfect bridge into our next section, integration and clinical reasoning.
Moving from the acute to the chronic.
Right. We are moving out of the acute recovery phases and looking at the chronic long-term psychiatric overlaps. Let's tackle the giant first, depressive disorders.
Depression is unequivocally the most common psychiatric complication following a TBI.
How common are we talking?
Depending on the longitudinal cohort studied, the prevalence ranges from roughly a quarter to over 3/4 of all patients.
Up to 77%. That's massive. But I want to play devil's advocate here for a second.
Go for it.
If I get into a catastrophic car crash and break my lumbar spine, paralyzing my legs, I am going to be profoundly depressed. My life has fundamentally changed.
Understandably.
If I suffer a TBI and lose my cognitive sharpness, I am going to be depressed. How do we know TBI depression isn't just a severe adjustment disorder? How do we know it's a direct biological result of the brain trauma?
It is a totally valid question.
Okay.
And researchers answered it through rigorously designed controlled trials.
How did they do that?
They took cohorts of patients with severe TBI and matched them against cohorts of patients with severe, life-altering orthopedic trauma.
Like the spinal cord injuries.
Right. Spinal cord injuries, massive amputations, people who had identical levels of resulting physical disability, and identical premorbid demographic backgrounds.
Okay, so the psychological burden of disability is the same.
Exactly. And when they tracked the rates of major depressive disorder, the TBI cohorts developed depression at drastically higher frequencies than the orthopedic controls.
Wow.
The psychological trauma of disability is present in both, yes. But the physical neuropathology of the TBI acts as an independent, massive biological driver for clinical depression.
So the brain damage itself is actively generating the depression.
It is part of the pathogenesis, yes.
Do we have the imaging to prove what circuits are broken?
We do. Volumetric MRI and functional imaging studies of post-TBI depression patients reveal a very consistent pattern.
What are we looking for?
There is significant gray matter volume loss in the lateral aspects of the left prefrontal cortex.
The left PFC.
Right. And functionally, you see a marked hypoactivation in those lateral and dorsal frontal regions, coupled with hyperactivation in the ventral limbic and paralimbic structures.
Like the amygdala.
The amygdala and the insula, exactly.
So the prefrontal cortex, the logical, regulatory brake system of the brain, is physically ground down by the skull, while the emotional generation centers in the limbic system are running unchecked.
And the brakes are broken, and the accelerator is stuck to the floor.
If the prefrontal cortex can no longer inhibit the limbic system, we shouldn't just be seeing depression, right? What else happens when that modulation fails?
You see a highly dangerous clinical
A
triad.
triad.
Major depression in TBI patients rarely presents in isolation. It is heavily comorbid with severe anxiety disorders and intense aggressive behavior.
Depression, anxiety, aggression.
Yes, the patient is depressed, constantly highly aroused, and prone to explosive rage.
That sounds exhausting.
It is. And when you combine deep dysphoria with unmodulated impulsivity and aggression, the suicide risk skyrockets.
I can imagine.
It is a lethal combination that requires aggressive psychiatric intervention.
And when we look beyond the structural damage, who is most at risk? I mean, if I'm looking at a patient's chart, what non-biological factor should make my warning bells ring?
The most consistent demographic and clinical correlate for developing post-PBI major depression is poor premorbid social functioning.
Social functioning.
Yeah. If a patient lacked a robust social support network or struggled to maintain interpersonal relationships before the injury, their risk of psychiatric collapse after the injury is exponentially higher.
Because they don't have a safety net.
They do not have the external scaffolding required to navigate the massive internal disruption.
That structural damage to the prefrontal cortex leads us perfectly to the concept of comportment.
Comportment.
How a human being behaves, regulates impulses, and conforms to social norms. And, I mean, you can't talk about prefrontal damage without bringing up Phineas Gage.
The most famous case in neuroscience.
The 1848 railroad worker who had a tamping iron blown entirely through his left frontal lobe.
He survived physically, his memory remained intact, but his friends famously noted he was no longer Gage.
He became profane, impulsive, and totally stripped of social grace.
Gage is the historical anchor, but the textbook provides a modern vignette that is chillingly similar.
Tell us about that one.
It's a 42-year-old construction worker who falls from a second story. He suffers bilateral orbitofrontal hemorrhagic contusions.
Right in that same area.
6 months later, his physical recovery is excellent, but his wife brings him into the clinic because he is a different human being.
Oh, so?
He's become hypersexual, demanding intimacy without any emotional connection. He flies into rages over minor inconveniences. He makes wildly inappropriate comments to strangers.
He has completely lost his social cognition.
Completely. The orbitofrontal cortex and the ventromedial prefrontal cortex are the areas that calculate reward, punishment, and social risk.
The social filter.
Right. When those networks are severed, the patient loses all insight into their own behavior. They become a slave to immediate gratification.
But the crucial takeaway from that vignette is that this is not an untreatable death sentence for their personality, is it?
No, it's not. The text explicitly notes that placing this patient on a selective serotonin reuptake inhibitor sertraline, in this case alongside rigorous behavioral therapy, resulted in a massive reduction in his hypersexuality and explosive anger.
So we can use pharmacology to artificially support the broken circuit.
Exactly. We boost the serotonin to help regulate the impulses.
Now, what about the opposite end of the mood spectrum? If depression is everywhere, what about secondary mania?
Mania following a TBI is relatively rare, occurring in roughly 2 to 9% of cases.
Still, that's not insignificant.
No, and conceptually it is incredibly revealing.
Why?
When a patient develops secondary mania post-injury, they exhibit the classic euphoria, grandiosity, decreased need for sleep, and hyper-religiosity we see in primary bipolar disorder.
Classic manic symptoms.
But epidemiological studies show that these post-TBI mania patients do not have higher rates of a family history of bipolar disorder compared to the general population.
Oh. That is a fascinating distinction.
It is.
Because if there is no genetic family history, it proves the mania is not just the trauma unmasking a latent genetic predisposition.
Exactly. It proves the physical trauma, the aberrant electrical activation or the localized destruction of right-sided limbic networks, is directly synthesizing a manic episode from scratch.
It is a purely structural phenocopy of a psychiatric illness.
Exactly right.
What about pathological laughing and crying, or PLC? Because this is another highly specific emotional dysregulation that gets misdiagnosed constantly.
Constantly. PLC is characterized by sudden, completely involuntary outbursts of intense emotion, usually sobbing or uproarious laughter, that are entirely disconnected from the patient's actual subjective emotional state.
The disconnect is the key, isn't it?
It is. You'll be sitting across from a patient asking them about their breakfast, and they will suddenly begin weeping inconsolably.
But if you ask them, are you feeling sad right now?
They will shake their head and say, no, I actually feel completely fine. I just can't stop crying.
The motor display of the affect is severed from the internal experience of the mood.
Which is known as pseudobulbar affect. And it's vital to distinguish PLC from major depression, because treating PLC requires different pharmacological approaches than treating pervasive anhedonia.
So we've mapped the clinical phenotypes, the depression, the dysexecutive failures, the comportment shifts. But as clinicians, we don't just want to guess at the damage based on symptoms. We want to see it.
We need objective markers.
Right. Let's talk about diagnostic tools and biomarkers. A patient arrives in A&E, and the protocol is an immediate non-contrast head CT. But a CT scan is essentially a blunt instrument, isn't it?
The non-contrast CT is strictly for acute surgical triage.
To see if they need surgery right now.
Exactly. It is designed to find massive, life-threatening pathologies. Epidural hematomas, large subdural bleeds, expanding contusions, or midline shifts that require an immediate craniotomy.
But what is it missing?
What a CT scan is notoriously terrible at detecting is diffuse axonal injury.
The microscopic tearing.
Right. You could have a patient in a deep, unresponsive coma with a GCS of 4, and their CT scan might be read as completely unremarkable.
Because the CT just can't see the tearing of the white matter tracts. For that, we need an MRI.
But even a standard T1 or T2 MRI sequence might miss the subtle shearing.
So what do we use?
We have to look at diffusion tensor imaging, or DTI.
Break down DTI for us.
DTI is a revolution in visualizing network connectivity. It maps the microscopic, three-dimensional diffusion of water molecules within the brain.
Water molecules.
Yes. In a healthy, intact, myelinated axon, water diffuses preferentially along the length of the tract. It flows down the tube.
Like water in a pipe.
Exactly. This is called high fractional anisotropy.
High fractional anisotropy. Got it.
But when an axon is stretched and torn by rotational forces, the myelin sheath degrades. The pipe is broken.
So the water leaks out.
The water is no longer constrained. It diffuses chaotically in all directions.
So the fractional anisotropy value drops.
Exactly. Using DTI, we can mathematically calculate that drop and generate a color-coded map showing precisely which white matter superhighways have been severed, even when a standard MRI looks entirely normal.
That is incredible. And we can go even deeper than structural integrity, can't we? We can look at the actual metabolic health of the surviving neurons using magnetic resonance spectroscopy, or NRS.
MRS allows us to perform an in vivo chemical biopsy of the brain.
A chemical biopsy.
Yeah, instead of generating an image, it generates a graph of metabolic peaks. And the most critical marker in TBI is N-acetyl aspartate, or NOBA.
NAA, what does that do?
NOA is an amino acid derivative synthesized almost exclusively within the mitochondria of healthy neurons.
So it's a marker of neuron health.
Exactly. The amplitude of the NAA peak is a direct, quantifiable marker of neuronal density and viability.
And after a TBI.
Following a severe TBI, we see significant, long-lasting depressions in NAA levels, and they perfectly correlate with the patient's cognitive deficits. It proves the neurons in that region are either dead or metabolically crippled.
Imaging is incredible, but, it requires a massive machine and an hour of the patient's time.
Which isn't always practical in trauma.
Emergency medicine has been searching for decades for a simple blood test, the troponin of the brain, a rapid assay to tell us if neural tissue is actively dying. What about blood tests? In medical school, we were all taught to look for S100B. Is that still the gold standard?
S100B was the focus of intense research for years. It's a calcium-binding protein that spikes in the serum after brain trauma.
So what's the issue?
The problem with S100B is its lack of specificity.
Meaning it comes from other places, too.
Exactly. It is not exclusively found in the brain. It is also present in chondrocytes and adipocytes.
Cartilage and fat.
Right. So If a patient has a multi-trauma car crash and breaks their femur, their S100B levels will skyrocket, rendering it completely useless for ruling in a TBI.
It's sensitive, but it's fundamentally flawed because of the peripheral noise. So what has replaced it?
The paradigm has shifted heavily toward glial fibrillary acidic protein, or GFP.
CF,
A GFAP is a structural protein expressed almost exclusively in the cytoskeleton of astrocytes within the central nervous system.
So it only comes from the brain.
The text highlights the massive multi-center TBI study. They compared all the emerging fluid biomarkers against standard clinical decision rules to see which was the most accurate at predicting whether a patient's CT scan would show traumatic abnormalities.
And GFA won.
GFA radically outperformed S100B. It demonstrated a 99% likelihood of improved discrimination.
99%.
Because it is so highly specific to astroglial damage, a spike in GFAB is virtually definitive proof that the brain parenchyma has been breached.
That is exactly the kind of concrete biomarker A&E has been waiting for. Now, I want to pull back from the skull for a moment and look at the systemic picture. We need to talk about endocrinology.
The brain-body connection.
Why on earth does a psychiatrist managing a patient's mood and cognition a year after a crash need to be deeply concerned about their hormone panels?
Because the brain is the master regulator of the endocrine system, and the physical link connecting the two is incredibly fragile.
You mean the pituitary stalk?
Right. The pituitary gland sits in a tiny bony cradle, the sella turcica, at the base of the skull. It is tethered to the hypothalamus by the infundibulum, or the pituitary stalk.
Okay, so you have the big brain, a tiny stalk, and a little gland in a bony pocket.
When the brain undergoes those violent acceleration-deceleration forces, the heady brain shifts, but the pituitary gland remains fixed in its bony pocket.
The brain acts like a wrecking ball pulling on its own tether.
Precisely. That delicate stalk and the complex portal venous system wrapped around it are easily sheared.
And what happens when they shear?
This physical severing creates profound endocrine crises. In the acute ICU phase, the immediate terror is hypocortisolism.
Low cortisol.
If the anterior pituitary cannot signal the adrenal glands to produce cortisol via ACTH, the patient will plummet into life-threatening hypotension and hyponatremia.
Their blood pressure just crashes.
Yes. Alternatively, damage to the post-pituitary pathways halts the release of antidiuretic hormone, triggering diabetes insipidus.
Where they can't hold on to water.
The patient rapidly urinates liters of dilute urine, leading to lethal hypernatremia.
Those are the acute intensive care crises. But let's look at the chronic phase. Let's say a patient comes to your outpatient clinic 12 months after a severe TBI.
Okay.
They are complaining of massive debilitating fatigue, severe weakness, increased fat mass around their abdomen, and a profound loss of their sense of well-being.
Sounds very familiar.
Right. The instinct for a psychiatrist might be to diagnose a severe atypical major depression and start rotating them through SSRIs and SNRIs. But what endocrine failure should you actually be looking for?
You must screen them for growth hormone deficiency, or GHD.
Growth hormone in an adult.
It is the most common anterior pituitary endocrinopathy to emerge in the chronic phase post-TBI. In an adult, severe GHD doesn't affect height. It fundamentally alters metabolism, body composition, and energy levels.
And it mimics depression.
The psychological presentation of GHD perfectly mimics a severe treatment-resistant depression or chronic fatigue syndrome. If you don't check their hormone levels, you will subject them to years of ineffective psychiatric polypharmacy for what is fundamentally a structural pituitary failure.
And timing is everything with this diagnosis, isn't it? The guidelines are very specific about when we should be drawing these labs.
Yes, you should wait until the 12-month mark post-injury to perform dynamic growth hormone testing.
Why wait a full year?
The endocrine axis is highly volatile in the first year. Deficiencies observed at 3 or 6 months might be transient adaptations to critical illness that spontaneously resolve.
So they might just bounce back.
Exactly. Conversely, a patient might test normal at 3 months, only for the fibrotic scarring in the pituitary stalk to slowly strangle the remaining blood supply, resulting in delayed failure at 10 months.
Oh, wow.
Testing dynamically at 1 year provides the most accurate assessment of permanent chronic pituitary dysfunction.
It is the ultimate reminder that psychiatrists must be physicians first. We cannot divorce the mind from the metabolic engine running it.
Absolutely not.
Now, as we enter the final act of this synthesis, we must address the most sobering reality of brain trauma, the long-term shadow.
Neurodegeneration.
We are talking about later life neurodegeneration, A TBI is not a static scar. It is an active variable in how the brain ages over the next 40 years.
The epidemiological data over the last decade has become incontrovertible.
It's that definitive.
Yes, sustaining a traumatic brain injury, even a single moderate injury, or repeated mild injuries, significantly alters your trajectory for developing neurodegenerative dementias decades later.
How does it do that?
Well, the trauma lowers your overall cognitive reserve. But more insidiously, it appears to actively accelerate the pathological aggregation of misfolded proteins.
Let's start with Alzheimer's disease. The epidemiological link is incredibly robust, right?
It is. Large-scale database studies have repeatedly demonstrated that a history of TBI acts as an independent risk factor for the development of Alzheimer's dementia.
And we can see this happening now.
We are beginning to see the mechanisms via advanced imaging. In cohorts of patients with a history of severe TBI, amyloid PET scans reveal greater deposition of amyloid beta plaques compared to matched controls.
The plaques are building up faster.
Furthermore, the clinical onset of cognitive impairment in the TBI cohorts occurs, on average, 3 to 4 years earlier than in patients without a history of head trauma.
The injury literally fast-forwards the neuropathological clock.
It really does.
But the textbook makes a fascinating point that it isn't just an Alzheimer's story. There are links to non-Alzheimer's dementias, and specifically, a very dangerous synergy regarding Parkinson's disease. How does mechanical trauma relate to a movement disorder?
The disruption of the basal ganglia circuitry and the chronic neuroinflammation initiated by the trauma appear to make the dopaminergic neurons in the substantia nigra highly vulnerable.
Which leads to Parkinson's.
Yes. In massive veteran cohorts, researchers found a clear dose-dependent link between TBI and subsequent Parkinsonian syndromes. But the truly alarming finding is the synergy with post-traumatic stress disorder.
PTSD. This is where it all connects. The physical and the psychological.
Precisely. If a patient has a TBI, their risk for Parkinson's is elevated. If they have PTSD without a physical brain injury, their risk is also elevated, likely due to the chronic allostatic load and the continuous toxic bathing of the brain in cortisol and stress hormones.
But if they have both?
If a patient has both a TBI and PTSD, which is incredibly common in military populations and severe motor vehicle accident survivors, the risk for developing Parkinson's disease multiplies synergistically.
It doesn't just add up, it multiplies.
The mechanical shearing and the psychological neurotoxicity combine to absolutely destroy the basal ganglia.
The trauma compounds on every front. Finally, we cannot discuss neurodegeneration without addressing the condition dominating sports medicine and neurology headlines: chronic traumatic encephalopathy, or CTE.
CTE is a distinct progressive tauopathy.
How does it differ from a standard TBI?
Unlike a single severe event, CTE is driven by the cumulative burden of repetitive, subconcussive, and concussive impacts sustained over years.
Like football or boxing?
Exactly. We see the professional American football players, boxers, rugby players, and military personnel exposed to repeated blast over pressure waves.
And what is happening inside their brains?
The constant mechanical stressing of the brain initiates a hyperphosphorylation of tau proteins. These form neurofibrillary tangles that slowly spread throughout the cortex, devastating the frontal and temporal lobes.
And clinically?
It leads to severe mood lability, impulsivity, suicidality, and eventually profound dementia.
CTE is the absolute embodiment of our opening metaphor. It's not one massive earthquake. It is 10,000 tiny microtremors over 20 years that continually weaken the foundation until the entire architectural structure of the brain simply collapses.
That's exactly it, which brings us to the core clinical philosophy of this whole chapter.
Let's hear it.
When you are managing a patient post-TBI, whether it is day 2 in the ICU or year 10 in your outpatient clinic, you are managing an evolving landscape. You are not trying to return them to a pristine baseline that no longer exists.
Because you can't.
Right. You are helping them build compensatory mechanisms to navigate their new neurological reality.
That is a profound way to look at it. Okay, let's distill everything we've unpacked into a few single best answer questions. A quick clinical reasoning check for you listening.
Let's do it.
Question 1. Which mechanism is primarily responsible for diffuse axonal injury? Take a second to think about that one.
It's the rotational and tensile shearing forces, which uniquely stretch and tear complex neurovascular and axonal structures, particularly in the corpus callosum and gray-white junctions.
Spot on. Question 2. During the acute traumatic encephalopathy recovery phase, what core cognitive feature distinguishes post-traumatic amnesia PTA from the subsequent post-traumatic dysexecutive syndrome? Think about the broken save button.
Right. PTA is characterized by the inability to form new memories due to hippocampal system injury, whereas this dysexecutive phase is characterized by difficulty retrieving memories and faulty encoding strategies due to frontal subcortical damage.
Excellent. Question 3. Which serum biomarker has demonstrated the highest discriminative value for predicting CT abnormalities in acute TBI, according to recent multicenter studies?
That would be glial fibrillary acidic protein, or GFAP, which is highly specific to brain tissue and outperforms S100B.
Brilliant. Question 4. A patient who sustained a severe TBI 1 year ago presents with profound new onset fatigue, decreased strength, and a diminished sense of well-being. What endocrine screening is specifically indicated at this stage?
Dynamic growth hormone testing. Growth hormone deficiency is the most common endocrinopathy post-TBI and is typically tested at 12 months, as earlier testing may reflect transient deficiencies.
Right. Question 5. A TBI patient develops major depressive disorder within the first year post-injury. According to the structural and functional correlations we discussed, what other two clinical manifestations are most likely to co-occur with this depression? We called it a lethal triad.
Anxiety disorders and aggressive behavior. This triad is linked to faulty prefrontal modulation of medial limbic structures.
And the final question, question 6. What is the most consistent clinical and demographic correlate of major depression during the follow-up period after a TBI?
Poor premorbid social functioning.
Fantastic. It is a phenomenal text, and as always, our discussion is a conceptual map designed to run alongside it.
Definitely. Go back, read the chapter, study the DTI scans, and integrate the physiology with the psychiatric phenomenology.
Here are the details of this deep dive.
Neuropsychiatric consequences of traumatic brain injury. Byline. Impact and aftermath, how injury reshapes cognition, emotion, and identity over time.
As we close the book today, I want to leave you with one final thought, a frontier of TBI research that is just beginning to unfold. We've spent the last hour dissecting how the mechanical forces of an injury tear the brain's hardware, unleash glutamate storms, and rewire the cortex.
The central nervous system damage.
Right. But what if the secondary cascades don't stay confined to the skull? Researchers are now finding that within hours of a severe head trauma, the gut microbiome rapidly and pathologically alters.
The gut-brain axis.
Yes. The sheer stress and the massive autonomic discharge traveling down the vagus nerve compromise the intestinal barrier, leading to a systemic release of endotoxins. Those gut-derived inflammatory signals then travel back up the vagus nerve, crossing the damaged blood-brain barrier, and essentially pouring gasoline on the microglial fires burning in the brain weeks later.
It's a systemic feedback loop.
It is. So, the next time you are sitting across from a TBI patient who is suddenly complaining of inexplicable gastrointestinal distress alongside a sudden worsening of their brain fog and depression, ask yourself, is the brain injury truly over, or has the epicenter just relocated? Keep asking those questions, keep challenging the boundaries of the pathology, and we will see you on the next deep dive.